Hey guys, how are you? This is gastroenterology, a long one, so buckle up. First, we're going to talk about liver and pancreas, cholelithiasis, bile stones, condition where there are gallbladder stones, gallstones in the gallbladder, obviously, which are hardened deposits of bile. Biles become hardened due to various conditions in the body, and we see gallstones. One of the main causes that you actually find out that the patient has stones in the gallbladder, the gallstones, is when the patient has high-fat meals, which cause hormone release. These hormones cause spasms of the bile. Gallbladder is a muscular sac. It spasms, and then there is a sudden onset of right upper quadrant. That's where the gallbladder is, just under the liver, right upper quadrant pain, which we call, this pain is called biliary colic, and it radiates to the right shoulder. Potentially it may radiate to the epigastrium and back if pancreas is involved. To reduce the risk of developing cholelithiasis, the condition where you have gallstones, you must avoid foods high in fat and cholesterol. And as we'll see later on, it's not just that. Bilirubin is a dark colored pigment that the liver forms by breaking down RBCs. RBC hemoglobin is broken down and excreted in bile. So this too can cause gallstones. So it's not just food, it's also breakdown of blood. Hemolysis can be a cause for gallstones. Abnormal yellowing of skin is called skin or sclera, especially that's where you look, the eye whites, is caused due to elevation of bilirubin in blood, hyperbilirubinemia, elevation of bilirubin, and therefore bilirubin deposition in the tissues, and this is called jaundice. All right, so patient can have cholelithiasis due to foods high in fat or bilirubin deposition due to increased breakdown of RBCs. Why is it important to not have cholelithiasis? Because cholelithiasis can lead to inflammation, itis, of the gallbladder, the bladder, the bile bladder, so as to say, the gallbladder, and this is not very good. Gallbladder inflammation is called cholecystitis. Obviously, it's also a right upper quadrant abdominal pain with or without radiation to the right shoulder, and as we said, epigastrium and back if pancreas is involved. You got to undergo a surgery if you have it. Surgery is called bile, cyst bladder, ectomy, cut out. Tomy is to cut, ek is out, cholecystectomy, or cholecystostomy, where in an opening, a mouth, so as to say, is made after a cut, tomy, ostomy, and in the where you can reach the cyst, the bladder, the gallbladder, cholecystostomy. Murphy's sign is a manual pressure that is applied on the ribs, as I showed you, and it elicits a right upper quadrant mid-clavicular at the nipple line pain in patient, and this pain results in patient stopping inhalation. You ask a patient to take a deep breath, patient stops taking that deep breath as soon as you press under the ribs. Murphy's sign is then called positive Murphy's sign. Choledocholithiasis is presence of gallstones in the common bile duct. Choledocholithiasis. Do not confuse this with cholecystitis or cholelithiasis. Choledocholithiasis, gallstones stuck in the common bile duct. This common bile duct drains gallbladder and the liver. You got to know what ascites is. Ascites is an abnormal fluid buildup in the abdomen, and most commonly due to liver cirrhosis. As we mentioned, liver has two functions. One is filtration, the other one is production of bile. Hepatitis viruses often cause liver cirrhosis. Hepatitis C is the most common cause of chronic hepatitis and can lead to cirrhosis, CCC, and therefore liver failure, because in cirrhosis, liver is totally scarred up and useless, can no longer execute its function. Hepatitis A and E viruses. E is very uncommon in the US. You will never ever see, very unlikely ever see anything related to hepatitis E, but hepatitis A is very commonly oral, fecal oral, i.e. mouth and anus related route, transmitted via fecal oral route. And I want you to remember it by thinking vowels go through your bowels. Hepatitis A and E, both are vowels. C for chronic. Hepatitis B has an excellent vaccine that works very well. We don't see it anymore, although it used to be the most common type of hepatitis overall. And now let's go to pancreatitis. Patients with pancreatitis present with nausea and vomiting and severe epigastric pain that radiates to the back, because as I told you in class, pancreas is retroperitoneal. This pain obviously is going to hurt even more when you lie down because you're compressing on it, right? And so fever and hypotension are just additional problems that you're going to have, especially if the patient is not doing well. Pancreas is responsible for fat digestion. When pancreatitis is a diagnosis, fatty stools are commonly seen. If you want to sound real educated, you want to say steato, fat, rhea, just like diarrhea, steatorrhea, all right? Menorrhea, monthly flow, okay? So celiac disease or celiac sprue is another cause of fatty stools. All right, so superficial bleeding under skin is sometimes seen in about 1% to 3% of patients with severe pancreatitis, and this is called Cullen's sign. These bleedings are rather large, ecchymosis, more than one centimeter. Ecchymosis, we had that in week 1, and there are skin or mucosal bleedings. Edema may also be seen, and Cullen's sign is when you see this bleeding around the umbilicus. It's not only pancreatitis that causes this type of bleeding. Any retroperitoneal bleeding, such as ovarial problems, can cause Cullen's sign as well. Please know that acute pancreatitis and chronic pancreatitis are most commonly caused by alcohol. However, gallstones are the most common cause, and gallstones are obviously due to fatty food, are most common cause of acute pancreatitis. Now let's do the gastrointestinal tract part 2. Let's talk about dysphagia. Dysphagia is just difficulty swallowing. It can be due to many causes. And do not confuse dysphagia, the term, with odynophagia. Odyno means painful swallowing. Please do know that achalasia means I cannot, relax, chalazion, okay? The Greek word. And this means that there is a problem with the lower esophageal sphincter. It cannot relax. And if it cannot relax, you have a motility problem. Food cannot go from the esophagus to the stomach. Therefore, you may have both dysphagia, i.e. difficulty swallowing, and odynophagia, i.e. painful swallowing. All right, why is it not listening? Let's go. All right, the second term that you need to know, and you probably do very well, is called GERD, gastroesophageal reflux disease. We did it in week 1. And we're also reviewing it now. Dysphagia, difficulty swallowing, and substernal burning is a given because acid from the stomach flows back and burns the esophagus, so there is a substernal burning. Delayed gastric emptying is often seen in patients with peripheral neuropathy, such as in your favorite disease for NCLEX called diabetes, diabetic peripheral neuropathy. Patients have Paresis, we're going to do the word paresis and paralysis in neuro. Gastroparesis is delayed gastric emptying. Partial paralysis, paresis. And GERD can actually be exacerbated, i.e. made worse due to increased reflux because food is not flowing forward, so it flows, acid flows back. All right, so there is a particular case of a so-called sliding hiatal hernia. Esophagus, before it joins and empties into the stomach, has to pass the diaphragm. When esophagus passes this level, so the diaphragm, there is a hole in the diaphragm which we call hiatus, okay, esophageal hiatus. So sometimes this hiatus, the hole before esophagus can enter the stomach, is a little bit loose. There is a defect in it, okay, at the level of the diaphragm. And so stomach can actually protrude. So this is the stomach sticking out, and the esophagus starts above the diaphragm. In the thoracic cavity, okay? So stomach protrudes through the diaphragm, a part of the stomach protrudes through the diaphragm, and because it protrudes through a hole, it looks like a number 8, okay? And because of this waist, it's called hourglass stomach, and this hourglass stomach can exacerbate GERD. One more thing that exacerbate GERD. So we talked about gastroparesis, we talked about and now we're talking about sliding hiatal hernia, and it's called sliding because the stomach comes out and then it comes back. It herniates through that opening and then goes back to where it should be in the abdominal cavity. This obviously presents with dysphagia, difficulty swallowing, as well as substernal burning, a typical GERD presentation, and should be treated with PPIs. PPIs stand for proton pump inhibitors, or surgery if necessary, if it's really bad. So just remember that bowel exit through a wall opening is that's the definition of hernia, okay? You got to have a wall and you got to have a previously present hole, so a wall opening, okay? Now let's do some terminology. Reducible, RE, repositioned, RE, original, pronounced as RE, versus irreducible incarcerated ischemia. Let's go. Irreducible, a reducible hernia, you can make it small, you can reduce it in size, can be repositioned, like we can reposition technically an umbilical hernia. A baby has something sticking out of the umbilicus, we can just press it back to its original position, and hernia is no longer. All right. Now, sometimes you cannot reduce it in size. Something comes out through that previously available hole, and you cannot reduce that protrusion. That's called irreducible hernia, or incarcerated, incarcerated hernia. All right. Now, what happens is that because of that incarceration, and ischemia is possible, you not only press on the organ, you also press on the blood vessels. If you press on the blood vessels, you know what happens. Tissue may die. You may have necrosis of the bowel wall, and this is called strangulation. You basically strangulate an organ. Strangulated hernia is called incarcerated hernia, in which the blood flow is blocked. So you need to understand that colonic walls sometimes, whatever the reason is, may have some weaknesses, right? Just like it's a long tube, colonic wall, we're talking about colon, it may have some weaknesses, localized, small or large weaknesses. In those areas of weakness, colonic wall may protrude, like usually like a finger, like a finger on a glove. And this looks like bowel outpouching that I showed you in the picture, and I told you it's called a chronic condition called diverticulosis. Chronic condition called diverticulosis. Now, These are diverticula, and you can see them on the imaging. You can see them on imaging, but patients have no clinical signs. Patients may live forever with those signs, and in fact, about half the population above 65 um, have diverticulosis and do not have any clinical signs. Wall weakness is just a wall protrusion, and we call it diverticulum. There may be sometimes obstruction of that finger-like projection, let's say closer to the wall itself, so the finger at the base of the finger, let's say something that's in the luminal contents, and we may cause an inflammation of that finger-like protrusion, right? So finger-like protrusion is inflamed, itis of the diverticulum. Itis of the diverticulum, diverticulitis. Now, do not confuse diverticulitis with hernias, because hernias are bowel exits through the wall opening in diverticulum. Diverticulosis and diverticulitis, there is no wall opening. There is just a bowel outpouching, okay? So opening versus outpouching. Appendicitis is an inflammatory disease seen with right lower quadrant pain. You know that it presents with umbilical pain initially, kind of like area around umbilicus is sensitive, and then it localizes to that McBurney point. And you got to treat it with surgery. And I put it here just so that you understand. Appendix looks like a finger-like projection, and it too can be blocked off at the base where it connects to the cecum, the colon, and get inflamed, and that's itis of the appendix, appendicitis, similar to diverticulosis, inflaming, and now we term that inflammation diverticulitis. Let's talk about gastroenteritis. Gastroenteritis is inflammation of the enteron, the intestines, and the stomach. Person-to-person transmission is very common. Water can be a source of infection. Food can be a source of infection. We then term it, if something is passed via food or orally, basically, we say fecal oral, right? We talked about hepatitis A and E as bowels go through the bowels, fecal oral transmission. Pathogens, bacteria, and toxins can both cause problems. What they do is they irritate the gastrointestinal tract, causing diarrhea. Gastroenteritis is just another name for watery and bloody diarrhea, or just a bloody diarrhea. Helicobacter pylori is a bacterium that you absolutely must know because it's the most common cause of peptic ulcers. Peptic ulcers are defined as ulcers in the stomach and duodenum. Stomach 1, duodenum 2. Rarely esophagus is also involved. Now, how do you test for peptic ulcers? You do a biopsy. You confirm the test with a biopsy, but after treatment, what you want to do is you want to ensure that the patient does other tests to exclude ulceration still being there. One of the tests that you may do is urea breath test. You just puff into an equipment. You may also do stool antigen test or antibody blood testing. Okay, you treat peptic ulcers with amoxicillin, clarithromycin, and PPI. It's called a triple therapy: amoxicillin, clarithromycin, and PPI, proton pump inhibitors. Don't forget to confirm with urea breath test, stool antigen test, and antibody blood tests. All right, that's very important to confirm because sometimes patients are missed and they developed cancer of the stomach, gastric lymphoma actually. All right, so ulcer means what? We went over this. Do not confuse ulcer with erosion. Ulcer indicates damage to mucosa and the deeper submucosa or even muscularis. Layer 1 mucosa, layer 2 submucosa right underneath, and muscularis, the third layer, the muscular layer surrounded by serosa. That's the fourth layer. That's your peritoneum. So sloughing off of inflamed necrotic tissue, the dead tissue of the dead mucosa, dead submucosa, etc., causes obviously abdominal pain because now nerves are exposed to acid. So there is either pain with meals or between meals. There may be anemia that's present. There may be hematochezia. Hematochezia is red blood with defecation. Hematoblood, chezia feces, or melena, tarry black stools, or hematemesis, where a patient vomits emesis of blood in severe cases. Don't forget that it's not just Helicobacter pylori that may cause peptic ulcers, although it does cause about 90% for your roughly 90%, depending on the location. NSAIDs, which are medications like aspirin, non-steroidal anti-inflammatory drugs, or alcohol. Alcohol can also cause ulcers. We saw that alcohol is the most common cause of gallstones and therefore acute and chronic pancreatitis. Erosion is not the same as ulcer. Remember that erosion only damages the mucosa. Ulcer damages the deeper submucosa and even deeper, potentially even deeper, that's muscularis. Erosion is much smaller than ulcer. Alcoholism is a risk factor also for cirrhosis, causing liver fibrosis. And you know what happens if liver is scarred? There is a structural damage. Liver doesn't function anymore, and if it progresses to cirrhosis, liver definitely cannot execute both of its function. One would be filtration of blood coming from the intestines, and the other one would be formation of bile. You need to know differences between Crohn's disease and ulcerative colitis. You know that in Crohn's disease, mucosa has that cobblestone appearance that I showed you because the healthy normal tissue is rising above and is just more prominent and thicker than the surrounding tissue that has scarred, and has been destroyed by ulcers and fissures. Fissures are deep penetrating traumas that go through the whole wall. In Crohn's disease, we have a damage to mucosa, submucosa, the muscularis, and the serosa. The colon in Crohn's disease has therefore skip lesions. So areas of disease are separated by healthy areas. Those healthy areas are the cobblestones. Passage of fresh blood with stew is called hematochezia. One more time, okay? Blood plus defecate. All right, hematochezia. Don't confuse it with hematuria. Hematuria, we talked about hematuria when we talked about nephritic syndrome. Nephritic syndrome in post-streptococcal glomerulonephritis. Melena, I already went over it. Passage of black tarry stools, blood exposure to stomach acid, enzymes, and colonic bacteria is thought to make that stool black. Do not forget cola-colored stool in post-streptococcal glomerulonephritis. That's your quote-unquote melena of the urinary tract. Varicose veins in the perianal region may sometimes be dilated and may bleed as well if the liver, especially if the liver is not functioning very well. Do not confuse varicose veins with hemorrhoidal bleeding. Hemorrhoids occur because of the prolapse of the whole rectal venous plexus in the perianal region. Just know the difference pretty much at the basic level. Steatorrhea, I went over it again. Steato means fatty, rhea flow. Steatorrhea can be seen in pancreatitis and celiac disease. This is sort of a review. Celiac disease is also known as celiac sprue, and it's an autoimmune intestinal damage. Autoimmune, there are antibodies against gliadin, which is found in basically products you can buy in the bakery. Okay, so what happens then is that there is a decreased absorption and steatorrhea, the fatty stool. Last thing you want to know is a thing called volvulus. Volvulus derives its name from valvere, which means to roll, and may present as a bowel obstruction. So obviously, if an intestine that has to be like so becomes like so, or even like so around its mesentery here, um, due to twisting, for example, in sigmoid colon around the mesentery. And I'll remind you that mesentery is a double fold of the peritoneum that wraps around the bowel, right? It's how the blood vessels get to the bowel. So this is the serosa, or which is the peritoneum. So basically, you need a surgical intervention. This sigmoid colon is found in the lower left quadrant. Obviously, diverticula are also found in the lower left quadrant. Don't forget that. And sigmoid colon is found in the lower left quadrant. So pain would also